Welcome everyone to Pandemic Anxiety and Family Stress with speakers Dr. Kathleen Klein, Chief Medical Officer at the Consortium Incorporated, and Dr. Michael T. Flaherty, provided by the PA Care Partnership in association with the Office of Mental Health and Substance Abuse Services, also known as ONSOS. Today's moderators are part of the PA Care Partnership. We have Nancy Massey and myself, Jamal Ford. If you have any questions at any time during the webinar, please use the Q&A option, which you will find when you run your mouse along the bottom of the screen. I will be monitoring the Q&A and will pass along all our questions to the speakers throughout our presentation. And now I will turn it over to Nancy to introduce our first speaker.
I want to just jump in with one quick fun fact here. Dr. Klein and Dr. Flaherty come to us from the Pennsylvania Psychiatric Leadership Committee. And obviously it's in Pennsylvania. And they got to know each other virtually, which is great, and be part of our conversation today. As we hear more about what it was like for all of us on this side and for all of those who were on the other side of providing care for us. So our first speaker today is Michael T. Flaherty, Dr. Michael T. Flaherty. He is a clinical psychologist with more than 38 years of practice. In 1999, he founded the Institute for Research, Education, and Training in the Addictions in Pittsburgh, Pennsylvania. Prior, he was the head of behavioral care at the St. Francis Health System in Pittsburgh and director of its Institute for Psychiatry and Addiction Services. During his tenure, St. Francis was the largest community hospital-based behavioral health system in Pennsylvania, serving over 32,000 individuals annually in behavioral health. In 1999, at St. Francis Health System and with the University of Pittsburgh Medical Center, he was the co-founder of what is today Pennsylvania's largest not-for-profit Medicaid behavioral managed care company, Community Care Behavioral Health. He was its first president and continues to this day on its board. He has authored over 27 federal and foundational grants and more than 45 articles, chapters, and monographs on topics ranging from pregnancy and addiction, the importance of community-based recovery-focused care, workforce development in behavioral health, overdose prevention, to the chronic disease understanding of addiction, and how each community must become the cornerstone for today's community's integrated population health. A pioneering leader in building the science of recovery over the past 15 years, he has spoken in 46 states on recovery-focused care model and has been a regularly invited advisor to the White House Office National Drug Control, assisting as an expert advisor in the first White House overdose prevention plan in 2015. As co-leader and facilitator of West Pennsylvania's initial overdose strategy, 2017, and in the design of Pennsylvania's overdose plan, 2018. Today, he serves as board president of the National Annapolis Coalition for Behavioral Workforce Development. As a subject matter expert to SAMHSA's Military, Veterans, and Family Substance Abuse Technical Assistance Center, as a board member of For All Seasons, Inc., Behavioral Health and Rape Crisis Center on Maryland's Eastern Shore, and as a member of the Pennsylvania Psychiatric Leadership Council. He also continues clinical practice while assisting communities, counties, and states to develop and implement recovery-focused behavioral health. Dr. Flaherty currently co-locates between his Murraysville, PA clinical office and Tillicman Island, Maryland, where he started, and oversees a pro bono mental health center and overdose prevention program for that rural community. In 2016, Dr. Flaherty received the Pittsburgh Psychological Association Legacy Award for his lifetime contributions in psychology and healthcare. Dr. Flaherty is also a retired captain, surface warfare, and in the U.S. Naval Reserve, with 27 years service on active and reserve duty, including active service in Bosnia, Desert Shield, and Desert Storm. He holds BA degrees in philosophy and psychology from the Pennsylvania State University and an MA and PhD in clinical psychology from Duquesne, I hope I said that correctly, University. He is especially proud of his 3 adult children and 5 grandsons. Thank you, Dr. Flaherty.
Thank you very much, Nancy. I should quit now while I'm ahead, I think. Such a wonderful introduction, and I thank you all. I'm embarrassed, and I see some names popping up of people I know that are saying hello, and thank you for that too. It's a great privilege to be with you this afternoon and to talk about how I personally cope with and learn from COVID-19. Next slide, please. I had a personal mantra. And when we were planning today's talk, Dr. Klein and I and Nancy and Jamal said, let's talk about our personal experience. So hopefully we could relate to you in the audience to see how you responded personally too. And what I did is I came to this island on Tillman Island, Maryland, where I about 10 years ago bought a home to retire in, but it has certainly not happened that yet. But I came here and I took my mantra as we locked down, that to gain strength and courage and confidence, you have to experience your fear and you have to go with your fear. Something I talk to with my patients in my practice. Face your fears to get stronger. It's actually a Native American philosophy. Next slide, please. So what did I do to cope with COVID in 1919, 2020, 2021, 2022? First, instead of winding down my practice, I expanded it. I simply could not do anything other than that. The increased demand for services for behavioral care, and additionally, the increased access to people who heretofore had not had access to behavioral care, such as those who were transportation inhibited, rural people, quadriplegic people who couldn't get into the mental health centers. And I also was really thrilled to see that the 12-step programs expanded during COVID. They opened up much more to access to things like AA groups, even in Athens. I was invited and joined PPLC as a support group. I can't underestimate that. Every Thursday we met, Dr. Klein and others who invited me to come along with them, and was supposed to be an academic interest to look at COVID. We ended up supporting each other much, much more, and this group of fine psychiatrists and other individuals. I went into an immediate study of past pandemics on my own. I wanted to see what we could learn from past pandemics, and there were several. Shortly, and I'll talk about it more, I published an article with Dr. Ken Thompson, the lead of the Pennsylvania Psychiatric Leadership Committee, on coming out of COVID better. We'll review that briefly. Additionally, I increased my outreach in the community with my pro bono mental health center here, and expanding services through telehealth, mostly into populations and homes, adding food, transportation. And last, I'm going to talk a little bit about drafted and disseminated weekly psychology minutes for people to cope with COVID and to what they were going through. So in short, I kept busy, I worked harder, I faced my fear, and I had them every day, and thought how I felt so much to people around me. Next slide, please. Telehealth, I just wanted to mention briefly, I could not have done any of this without telehealth. The day of our computers, our cell phones, and telehealth is opening up new frontiers every day. And I can't tell you how grateful I was to be able to use it. I did a therapy session with a woman who had panic attack before she was delivering a baby. I had several people in wheelchairs who couldn't even get out of the house, all because of telehealth. And I certainly hope we don't lose that opportunity going forward. Next slide, please. First article that we pulled together, Dr. Ken Thompson and myself, was to, how do we come out of COVID better? And you'll have an access to this article. Nancy tells me she's going to submit it to the people who've attended today. But this was done in June of 2021, so the timing is important. But we looked at the epidemics and pandemics of 1889, 1918, and other major catastrophic events using some of the other early research by foundations in England and elsewhere. And we came together to see that there were patterns, common patterns of how societies have both experienced and handled pandemics and epidemics and other things. Next slide, please. This was one of the charts we had in that article. We used this from SAMHSA. This was their phases of disasters. But at the time we wrote this in 2021, we were down there where it says trigger events. In the middle, we were disillusioned. We weren't sure how we were going to handle it. We were getting mixed messages. Do the vaccines work? Do they not? What kinds of things should we take? Should we wear a mask or not? All of that. So we'd gone through this period. The honeymoon period is, of course, when we were hearing messages like, it won't come here. And today, I would say we are well into the reconstruction phase on this chart. So it's there to see that there are patterns of response of societies to pandemics. Interestingly, the same pattern would be found if you talked about how a person overcomes their alcoholism or drug addiction. You would see the similar movements. Next slide, please. Finally, we came out of that article. We must learn that to evolve, to come out better, and this is 2021, remember, it's not about our self-survival or the survival of a group over another group. It's demonstrated in both the disaster responses and in personal recovery. Similarly, it's about a commitment to the survival of everyone, the least, leaving no one behind. By doing this, we will all reach a better new normal if we have the will for it. And that was what we wrote in 2021. Everybody had to be considered. And there's my email if anybody would like to get the article if you don't get it otherwise. Next slide, please. This was a link, and I'm going to ask Jamal to take us to this webpage of a local church where I channeled my energies on the island, and Jamal's opening it up. Here you see the webpage of the Tillman Island United Methodist Church. Healthy Tillman is the pro bono mental health center we have on the island. It's now 7 years old, and we have about 500 people here. Many of them come to their therapy sessions and with or without shoes and things. It's a great place, quiet, but it was saturated by people during COVID from New York, Washington, Philadelphia, Pittsburgh. They all came here to get away from COVID. So we just grew incrementally during COVID. If we go back up here, you can see I'm going to ask them all to go to the link for coronavirus. And here you will find the specific page that we had pulled together during that time. There are hotline phone numbers and police, what to do in emergencies, going on down to messages from, how do we overcome powerlessness and how do we deal with despair? Everything, the Irish poems, of course, we had to have an Irish poem. Kindness is the language of the deaf can hear and the blind can see. The phrase there, fear is optional. That's something I use in my therapy. Your fate may seem decided, but fear and worry is always optional. There are people who that we are just going through these tips, and the Serenity Prayer, I think, was something we all went to. I invited people from the pastors and the faith-based organizations, not just on the island. We didn't have that many, but in the community. So we had representatives of each denomination and faith write inspirational messages for the community. Also tips regularly on what to do with families and kids. Now, if you look to the right on this page, you'll see these 30 odd some psychology minutes. And what I did during COVID was write one of these every week for over a year. Sometimes they came out every 2 weeks, sometimes usually every week. And you can see the topics: dealing with isolation psychologically, how to manage isolation, dealing with fear, the power of relationship at a time like this, power of gratitude. And each of these had messages and some uplifting thoughts so that people could use them. I started with about 14 on my email list, and when I submitted my last one, I had well over 2,000 people receiving each one, including a couple of universities, nursing schools and things. So it kept growing and growing, people saying, add me to your list. We're going to look at one of these. If we could go to number 13, I think, Jamal. This will give you an example of what they were. So this would come out on a weekly basis. And here I took the story of Sir Ernest Shackleton and his adventure with the ship Endurance, appropriately named for going through COVID with the name Endurance. But he took a ship trying to find the North Pole in 1915 with 27 crew members. They got to the North, but they got locked in an iceberg and were without communication, had no electronic communication, and stayed on this iceberg floating for 2.5 years. The message was, what do I do to cope with 2.5 years? So I studied what Mr. Shackleton did, and they had dog races with the sled dogs. They kept their food, every day it was a different ration, warm food. But he said, I knew the heads and thinking of every member of my crew. And he said, even though at night I went into my own room and wrote in my journal about my almost unbearable back pain and anxiety, no member of my crew ever saw this. And they took a lifeboat from the boat, which was eventually, the ship was crushed. They stayed in a lifeboat, these 27 men. They had 2 or 3 lifeboats, went across the ice, and 2.5 years later found civilization again, as they found an island finally where the lifeboats were able to take them to. His message to everybody at the time was that happy is the person who has learned to let go what he or she cannot change. Secondly, he said what we had to do every day to cope was put a foot of courage into the stirrup and charge on. Foot of courage every day and charge on. So this is a sample of one of the psychology minutes. So the story people would read, they would comment, have dialogues going back and forth. Go down to the bottom here, Jamal, please, if you would. I'm going to ask him to click on the YouTube presentation because each one of these had either cartoons or music attached. Now, you may get a brief commercial here. I hope not, but you will. This will be an example. There you go. Please watch the father here too.
Pray you'll be alright, and watch us where we go, and help us to be wise in times when we don't know. Let this be our prayer when we lose our way. Lead us to a place, guide us with your grace, to a place where we'll be safe.
I pray we'll find your love.
I pray we'll find your love
And hold it in our hearts.
and hold it in our hearts.
When stars go out each night.
When stars go out each night.
Remind us where you are. Let this be our prayer.
Let this be our
When
prayer.
shadows fill our day.
When shadows fill our day.
Lead us to a place, guide us with your grace, to a place where we'll be safe. A world where
Thank you, Jamal. Go back to the presentation. So if you would want to any of those messages or psychology minutes, you can just go to that website or contact me. And each had songs or even cartoons. And I think we need to go on forward, Jamal. This is from a prior. There, next one. There you go. This one you may have seen earlier in the announcement of the conference or the webinar today. One of the, actually several of the psychology minutes had to do with the mind of a child during COVID and what is the mind of a child. So I had asked people to submit drawings from their children, and I got many. It was quite interesting. This one came from New Hampshire, from a young man, 4-year-old, and his mother has given me permission to share it with you today, and you saw it also in the announcement of today's webinar. What does a 4-year-old tell us what COVID looked like? Well, to the left, you see a red building. That, believe it or not, is Target, the retail store. To the right in green is he and his mother. And in the middle, the black scribbly was COVID. And what he wrote to me in the drawing was, COVID is preventing me from getting to Target, preventing my mom from getting to Target, which I took as a good sign. It told me that he still had his mind in the right place and not panicked or immobilized by the fear of COVID. And I give the mother and the young man a lot of credit. Next slide, please. Lastly, and most recently, in March of this year, the Pennsylvania Psychiatric Leaders Committee had a conference, and they asked if I would speak on the topic of COVID. And I chose one topic of the politics of the pandemic. And we all know it was quite controversial to have gone through that time. So I presented this at the conference in March. Next PowerPoint, please. What are the ethics and politics of a pandemic? Why is that important? A pandemic is both a health and a political concern. You can't just say science says or physicians say, because it's disseminated through political leaders. So you have to include politics in the dissemination of advice during a pandemic. It's just too big. Leaders are elected, though, and they are elected to lead. Both ethics and politics deal with the social life of us all, really, behavior and the way human beings relate to one another and perform. Ethics examine the good of the individual. Politics ideally should examine the good of a city, the city-state. There, I'm borrowing from no less a person than Aristotle. Next slide, please. This is a real quick flyover of a much larger presentation. What happened during COVID? We made things worse. When the message was wrong, and many of them were, such as it's not coming here, or it won't affect this group or that group, we lost trust in the science. If the message was contradicted, which almost all of them were sometime, behavior just wouldn't change. If the message was politicized, irrational, sensationalized, which so many of them were through the media, trust and a sense of security is lost. If the message creates fear and confusion, anxiety grows, and altogether trust is lost. People retreat then, when all of this happens, into their own personal belief and who they trust. Next slide. I think it's the last one. So how did we do during this past 2.5 years? Looking at 1889, the alleged Russian flu, in 1918, the Spanish flu, misnamed as such, and who didn't have a vaccination, and both had wars going on at the time, so they had to mobilize and fight a war while in the middle of a pandemic. I gave it a grade of about the same. Considering we had a vaccine, probably we did worse during this modern response especially if you consider what ethics mean. Did we respond ethically? And the answer for that is, I don't think so. Next slide, please. What this statement, I would like to ask you all to, if you could, keep a copy of it or take it and use it and take it back to your organization, or just think about it. This was a compilation in the article of all of the science to date and how we should respond more appropriately in a pandemic. For example, there are actual numbers of people who would have been saved if the information was given with someone of neutral presentation politically, or if bipartisan information was given, lives would have been saved. And this particular compilation is a thematic compilation qualitatively of the best way to handle coming out with messages during a pandemic. And it's just a straw one. I'd like to get it better, and anybody who takes it and makes it work, makes it better, or give it to somebody, maybe we can change some things better next time. Last slide, please. Oh, there were effects on the family, which I know Dr. Klein's going to talk about. The families were definitely impacted, living together in crowded homes, the effects on certain populations, African Americans, Latino, elderly, group homes, nursing were highest. Lower incomes had to work. They had no remote jobs. They get double whammies, as Dr. Fauci said. They had increased health risks, but had to work and work in crowded places, and also had higher determinants of poor health. Impact on women was greater than men. Caretakers, children, elderly suffered more during this COVID. Next slide. Okay, I'm going to, in the sake of time, just go to the next slide. This is Dr. Fauci and what he said last week in an interview, and I am quoted, yes, we could have done better. He said we never got quite to the point where we were leading the conversation with anybody. So where am I today personally? I'm just trying to understand pandemics, remain prepared for the next one, know who is likely to be impacted in the next one the most, and minimize that impact now instead of waiting. We weren't ready for this last pandemic, so our systems were just completely caught cold. We should take the attitude that a death in Nigeria or Wuhan should mean just as much as a death in Pennsylvania. Practice ethically and practice more kindness. We have to improve our socialization and appreciation of one another. Know what a democracy is and how it works. A democracy isn't the voice of one or a few. It is that voice, but in aggregate for e pluribus unum, one of many. Find morality again. And there is a civil morality we have to be able to locate and find in our society unless we continue to demoralize ourselves. Find ways to express these values and make them applicable for all. And that's my presentation. Thank you very much.
Nancy.
Mike, I want to thank you so much. It was, I've already read through it and talked about it with you, and still it touches me deeply. And we all appreciate what you had to say and look forward to talking about that more. Next, we have up Dr. Kathleen Klein, and she is Chief Medical Officer at the Consortium, Inc., a recovery-oriented nonprofit community mental health center established in 1967 and one of Philadelphia's 12 CMHCs. Kathleen Kovner-Klein is a child, adolescent, and adult psychiatrist who began her faculty career at Dartmouth Medical School and continued as Associate Professor of Psychiatry at the University of Colorado. Medical Director of the Psychosocial Research Center and Mood and Thought Disorders Clinic at the Children's Hospital in Denver. She currently serves as Chief Medical Officer of the Consortium, which provides behavioral health, addiction, early intervention, and community support services in Philadelphia. In addition, she serves on the affiliated faculty at the University of Pennsylvania and Children's Hospital of Philadelphia. She is the author of several book chapters, papers, and monographs, and the editor of 2 books, Authoritative Communities, The Scientific Case for Nurturing the Whole Child, and Gender and Parenthood, Biological and Social Perspectives. She is particularly interested in evidence-based practices, systems of care, and the role of character-shaping institutions in promoting psychosocial well-being and supporting those with behavioral health challenges. Thank you, Dr. Klein.
It's great to be with you all, Nancy. Are we all set to go?
Say yes, Jamal.
We are.
Great, good. Well, thank you, everyone. Although I have a bone to pick with Michael. I have to say, it is absolutely not fair to put on a very touching and poignant song before someone else is about to give a presentation, because it gives tears to your eyes and you have to regain your composure.
Sorry.
So I found myself able to move on, but it was really quite beautiful and quite related to where we're going to go here. So that Daughter Daddy song was one prayer, and I'm going to start out with another one that's very close to all of our hearts, and really an anthem for many folks in behavioral health. It's the Serenity Prayer, which I know you're all familiar with. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. That was originally coined by famous Protestant theologian Reinhold Niebuhr many, many decades ago. So I think it's a good theme for one to get through a pandemic and to continue with in one's journey. So next slide, please, Jamal. So one of the things I want to do is we're going to tell our story a little bit, the story of how we've moved from the beginning of the COVID pandemic to the endemic era that we're in now. So I think this causes some confusion, but I want to think together about this definition of pandemic and endemic and the difference and the transition. This is from the Advent Health community. A pandemic occurs when an epidemic, the outbreak of more than the expected number of a disease cases in a small population, vastly spreads over a large geographic area, in this case, the world. Pandemics are known to cause widespread disruption, illness, and hardship, as we have experienced since 2020. An endemic means the disease is spreading in a community at a normal or expected level. A pandemic begins to shift to an endemic once the disease becomes more stable and manageable. It does not mean that the virus goes away and that there won't be occasional outbreaks. It's just less intrusive in daily life. And so I think what we are processing here together is in many ways our journey from this traumatic crisis, the onset of the worldwide COVID pandemic, causing many, many deaths, and arriving into the endemic stage where we are learning to live with a certain amount of COVID that will be with us for the foreseeable future, and how we will manage it from day to day and get our lives on track. Next slide, please, Jamal. So we're going to think about just for a minute together what happened, where we've been, and where we ourselves are in our recovery, our stabilization, and in our plans for the future. Next slide. So the first thing I want to do is to highlight our diversity and the diversity of the 804 people who are attending this webinar right now. I know many, perhaps most, are from Pennsylvania, but we are different in we are diverse in many ways. We have much in common, but we also are very diverse. And all these factors affected how we were affected by the pandemic and how we experienced the pandemic. We are diverse in terms of age. Some are children, some are young teenagers, young adults. Some people are the beginning of the careers, the middle, the end, some have retired. We differ in race, in ethnicity, in culture, in our belief system, in our politics, in our regions. Some of us are rural, some suburban, some urban. Some have different sexual identities. We differ in terms of life stage, in terms of our livelihoods, our living situations. We differ in terms of our baseline health status, our incomes, our media use, and even our temperament. We also differ in the experience we've had before the pandemic and the responsibilities we had and have during the pandemic and currently. Next slide. So what happened to all of us? COVID appeared on the scene in the United States as a new, serious, highly transmissible infectious disease. There was an initial dramatic surge in people sick and dying and overwhelming our healthcare system. There was an initial lack of immunity, vaccination protection, and established treatments. We were all in crisis. Next slide. So what was our initial challenge? Our initial challenge as a community, as a country, as a state, as a city, and as a town, and as families, was how to care for each other, but also how to protect ourselves from each other. Because the virus, as we know, is passed from individual to individual. Next slide. So that attempt to protect ourselves from each other led to, and the presence of the virus itself, led to enormous losses and disruptions. Many of us lost loved ones. Some lost livelihoods. There were challenges to financial stability. Some people lost their businesses and their jobs. Some people lost their hopes and their dreams. There were disruptions in services, supplies, and support. And for those of us in behavioral health care, there was a lot of changes in the healthcare system in general, and particularly direct services, including case management and other forms of support and therapy that people have grown accustomed to and benefited from. Most importantly, I think there were disruptions in our normal rhythms and routines. These are things that affected everybody. The normal rhythms and routines of school, work, recreation, faith-based involvement, shopping, physical activity, all changed. And they all changed for almost everyone. There was also, because of social distancing, a tremendous disruption in our social connectedness. We all faced erosions in our social networks and a loss of our social capital. Now, our social capital, for people who aren't aware of that term, if we think about capital, we're all used to financial capital, which is the money one has in one's bank account, or financial app for younger people. Our social capital is that cumulative store of social relationships and social connections that feed us on a daily basis and give us social support and nurturing in our daily lives. You know, the most obvious and basic kind of social capital is in your family. But it's not just in your family, it's in your other relationships. It's your an extended family, it's in your relationships with people at work, it's in organizations of civil society like churches and community groups and PTAs and bands and choruses and hiking groups, all sorts of ways that other people get together to support each other in informal and some more formal ways. And there was an erosion of all of that in all of our lives. And in many ways, I think that has going to be what has some of the longest lasting effects from COVID. We all know that people had tremendous amount of anxiety and fear and depression. But I want to take a moment and just look at some of the numbers behind our distress in the first pandemic year. We in psychiatry, we like to count things. So there is a lot to count in the COVID pandemic. I want to talk about the first year primarily because that was really the initial shock to our system and the initial and most dramatic disruption. By March of 2021, 520,000 individuals had died of COVID. I think we're all familiar with, 2+ years into the pandemic, that number is now at 1 million. But that's a tremendous number of people. In addition, in terms of children and families, 140,000 children lost a parent or a grandparent caregiver in the first year of the COVID pandemic. Those are irreplaceable losses and deep devastation in family life. Drug-induced deaths increased by 30% during the first year of the pandemic, and alcohol-induced deaths increased by 27%. Those, of course, are only the most extreme manifestations and really the tip of the iceberg. I can't imagine how many people experienced increasing despair and dysfunction represented by their increased drug use and alcohol use that fortunately are still here, but were really affected deeply by the strains and stresses of the first part of the pandemic and used their drug and alcohol as part of their coping mechanisms. Let's move on to the next slide. Here are some of the numbers in particular behind our children's distress in the first pandemic year. As mentioned earlier, 140,000 children lost a parent or grandparent caregiver. Children's mental health emergency department visits increased. They increased 24% in 5 to 11-year-olds in the first year, and they increased by 31% in 12 to 17-year-olds in the first year. Youth suicide attempts increased 22% in the summer of 2020, and then again increased up to 39% in the winter of 20 to 21. There was one interesting fact is that this is especially true among females. Okay, next slide. So that gives us a little portrait or look at the numbers for where we were a year ago. But let's change our focus a little bit and think about where we are today and where we go from here. I like to think of us now as survivors, rebuilders, and reimaginers. What does it mean to be a survivor? Well, the first thing I want to express is give gratitude to all of those who got us through the pandemic thus far. We all know selfless heroes on multiple fronts, sung and unsung. We've talked a great deal about, especially in the early days of the pandemics, the doctors, the nurses, the support staff, custodians, the techs, everyone who kept our hospitals going under this tremendous stress and strain of a new infectious illness, slaughtering hundreds of thousands of people. It brings tears to my eyes even now as I think about that. I also want to think about other people who maintained other services and healthcare systems, right? So there were those of us, I know Michael and I are familiar with all the people in behavioral health who suddenly had to figure out, how do we continue to offer care to our members, patients, and clients who are in need of increased support at this time? And so many of us could work remotely, but there were also a lot of people on the front line in direct care, in nursing homes, in supports coordination, in services to the disabled, in supporting folks in residential treatment and congregate care, who were both continuing in the face of their own mental health stresses, in the face of their own fears of infections, in the face of their own responsibilities to themselves and their own families, continued to persevere and offer care to others in need. Firemen, policemen, emergency responders, mobile crisis workers, all those people are service people who put themselves on the line. Everyone who helped with that and who helped with the vaccination, not outreach, but dissemination, being there, being present, putting themselves on the line and putting themselves at risk when people need care and continued care. So I'm going to start with gratitude. The second thing I want to acknowledge that as survivors, we need to continue our own process. As we talked in the beginning, we are diverse in many, many ways. And people process and cope with grief, loss, and change very differently. Not only do we each individually process things differently, but we also experienced the pandemic differently. If you were living in New York City in March of 2020, when the sirens went day and night, getting people to the hospital with COVID and being locked in your apartment, your experience was very different from someone in a rural situation who had not yet seen the virus yet, but perhaps was experiencing a tremendous loss of services that gave them support on a daily basis. So we all have had our own experience, and we all are at a different spot in our process of processing that experience, what we learned from it, what was a stress and strain, what we've recovered, and where we are. Some of us on this call have moved on completely, and that's all okay. Another thing I want to mention is that as survivors, we need to appreciate unexpected gifts from the pandemic. I know it's hard to imagine that there were any gifts, but changes in our lives bring challenges, but sometimes they also bring opportunities. Many of us had more family time together. Many discovered new means of communication and contact with others. Michael and I have a new relationship that we didn't have before the pandemic, and I'm grateful for that. And I'm grateful for all the relationships I have with other leaders in our field. And I'm grateful for the intensified sense of teamwork that I experienced with all the members of our own organization, the consortium in community mental health care and drug and alcohol care and supports coordination, but also all the leaders in Philadelphia as we struggled together to try to figure out how to continue to support each other and do the work we needed to do. And then lastly, I want to highlight that as survivors, we need to learn from our successes and from our mistakes. And there were many of both. Next slide, please. Next, I'd like to focus on us as rebuilders. And this is time, whenever you're rebuilding, you got to start at the foundations. What are the foundations of mental health? Well, first of all, physical well-being is a foundation of mental health. You can't have a healthy, it's difficult. It's not impossible, but it is difficult to have a healthy mind and a healthy brain without overall physical well-being, without substantial food, clothing, shelter, etc. But also equally as important, we know, is our social connectedness. And this was very challenged by the pandemic. And things are not where they were previously. And a third component, I think, of a foundation of mental health is our connectedness to transcendence and to purpose. Tom Insel, who used to be a professor at Emory and then the director of the National Institute of Mental Health and has now moved on to other psychiatric ventures, has a new book out, and he talks a lot about place, people, and purpose as the foundations of mental health and as the foundations of recovery. And in that same theme, I think we need to focus on these foundations, both in our personal lives and in our institutional and work lives. We are in the process of rebuilding our social capital. And every individual and family in this webinar is going to have to do that in their own way. They're going to have to build, rebuild, and restore connections with other people, and also connections with other groups and institutions. You know, many group-oriented organizations were stressed during this period, and some have just closed and folded. You know, many civic organizations, many groups. People couldn't be together for sports activities or choirs or other gatherings of any kind, faith-based institutions. So it's going to require us to actively rebuild those groups and institutions that we feel are valuable and provide the infrastructure for our social connectedness. And finally, we need to rebuild our healthcare and behavioral healthcare institutions. We've survived, but we've been challenged. We've been given some new gifts and opportunities like telehealth, but other services have frayed, and we need to think very carefully about how we reinvigorate our workforce and how we rebuild those institutions and structures and agencies. Next slide, please. Finally, I want to think of us as reimaginers and advocates. What do we need to restore? What new things should we continue? What else might be helpful? What old things should we continue? What are we willing to try that we might not have tried before? And what are we committed to do? I think these are good questions for us to consider as we spend some time together for the rest of this webinar. But these are important things. This is also a time to innovate and a time to recreate. One of the things when I was reflecting with our group at the Pennsylvania Psychiatric Leadership Community, I was mentioning that I had a recent trip out west. And for those of you who have not had the opportunity to visit the West, I encourage you to do so either in person or if not, via screen, because we have some of the natural wonders of the world in our country out west. And I was fortunate to get to the Grand Canyon and other of our great, great, great national parks. And it's also inspired me to visit some of Pennsylvania's great, great state parks as well. But, you know, in the West, they've had a lot of fires. And during many of those fires, whole hillsides have been turned to charcoal. And among them, you'll see a hillside that's black with tall black charcoal sticks that are remnants of the pine trees that have been destroyed. But alongside with them on those hillsides now, you see new little aspens growing up. Their seeds were planted who knows how long before, and the sun is shining and there's been some rain and they're springing up and they're coming back and they're bringing new life. So I want us to encourage, as many things have been, some things have been destroyed, some things have been transformed, many things have been changed. And as we rebuild, let's also pay attention to the new things that are happening and try to embrace and nurture them as we move to the next day. So finally, next slide, I'm going to close the way I began, which is the serenity prayer. God grant us all the serenity to accept the things I cannot change, the courage to change the things that I can or we can, and the wisdom to know the difference. Thank you, everyone.
Thank you, Kathy. That was wonderful. Jamal and I are moving into a 4-person screen coming up here as he resets the screen. And we're going to have a conversation. Part of that conversation is going to be based on questions that were put in Q&A. And I'm going to warn y'all, I have like 7 questions sitting here written down waiting to ask. So if you don't get your questions in the Q&A, I might beat you. So please, if you have questions, put them in the Q&A. As I was listening to the two of you talk, I have an idea for another webinar. And I'd like to call it the Reimaginers. And I know who I'd like to ask to be here for us to do that. And I'm going to be taking a poll later in the webinar and to get some feedback from everyone about that. There was some questions about stats, and I know that Dr. Flaherty is truly skilled around stats. And so I would like to bring this one to him. Someone said, oh, I wish you could have said whether it was a US stat or a world stat. And I'm feeling pretty confident that most of what was talked about here in this webinar was US. But I would also like to say that one of the most disturbing parts of the pandemic to me, as I was isolated and alone in my apartment for a good year, was there were no real stats being taken. And so I'm not sure, you know, when there's a concern about is it from here or from there, how much real evidence we have. I saw another comment about how do we know that the suicide stats are correct? And so if I may, I'd like to throw that to Dr. Flaherty.
Well, I'll get my crystal ball for you, Nancy, and we'll give you an answer. We did it through a number of ways, or at least researchers did, on prevalence of requests for service, increases in requests for service, increases of behavioral healthcare concerns during COVID. For example, the suicides did go up, anxiety was measured at mental health centers and locally and demographic studies to get those numbers. The suicide did increase. Some of the overdoses increased in some populations, but drug and alcohol programs really opened up their doors, so that helped. So where did the stats come from? There is a lot of data currently coming out of the National Academy of Sciences on data from COVID and where they got them. They maintain ongoing studies, epidemiological studies, annual epidemiological studies of use of services and demand for services, and they report that. Some of it came from more anecdotally from churches and communities and local mental health centers, health departments. In this little world here where I am, we saw a domestic abuse go way up all of a sudden, and that data came from the chief of police. So we took that there. So it goes from that small level, if you will, from the chief of police telling us what's going on in the community, to such a large epidemiological analysis as the National Academy of Sciences. It doesn't reflect all the data. You're right. I mean, data has a way of reinforcing itself because of gathering what we're looking for by intention. But there are lots of other data. But you have to remember with COVID, and this will be the last sentence, some people who got vaccinated got COVID. Some people who didn't get vaccinated didn't get COVID. The golden rule of a pandemic is, it's like, if we said it's like herding cats, we would be kind. It's personal, it's demographics, it's detriments of healthcare, it's risks underneath that. It's as we said earlier today, it's political and psychological. Some people did well, some didn't, and you just do the best you can for the most you can, which is the ethical argument I tried to make.
Thank you, Dr. Flaherty. Jamal, did you want to jump in with any questions, or should I keep going?
No, I actually have one. I have a few that have been asked in the Q&A. Catherine asked one that stuck with me. She said, how do we as professionals in the social service field help consumers rebuild trust in the aftermath of COVID? And that question I find interesting because I feel like the pandemic created a lot of distrust in a lot of things in our country. And what you were just talking about as far as the statistics and what is really a COVID related death, and are people really suffering as much, and a lot of things, and people question a lot of things. But how do we start to rebuild that trust in the aftermath of COVID and everything?
Kathy, you want to go first?
You're on mute, Dr. Klein.
That's a great question, and it's really an enormous question because the first thing, my first two thoughts are rebuilding trust depends on why trust has been challenged, and again, that's different for a particular individual. The other thing I would say is that trust is built again from relationships and relationships over time. And so we have to restore those relationships. One of the things that I didn't get to go into to detail in this brief presentation were two things that I think have had a big impact on us throughout the pandemic, but whose origins are way before the pandemic, actually, were the evolution of the media landscape, where financial rewards for folks on the media landscape are made by increasing people's anxiety, conflict, sense of being enraged, clickbait, right? So that is a challenge to both. It's a challenge to our basic cortisol and stress levels on a daily basis. And it's also, there's a lot of fodder that's made from actually building conflict and dissension, because that's what gets interest from people in many ways. And that's what helps rally people to sort of their causes. And related to that is just the tremendous conflict and dissension that has been in our community life for a while. This really kind of crazy polarization where people can't talk to each other, and they have lost some of the skills of being together and talking to each other and tolerating different points of view and different perspectives. And I think we all have to work on that at a very basic level in our families and in our communities. And that happens not immediately, but over time, over repetitive interactions, showing patience, forbearance, and active listening, I think.
I think Kathy raises some excellent points. I would say that at our last meeting of the Psychiatric Leadership Council, we had an interesting conversation on the point of have we lost hope in this society? And why have we lost hope? It's because we have begun to distrust too much. We've lost trust, and it's too, everyone is too individualized, thinking that they have the right themselves to dictate the world. And with the messages coming out of different parties, it's so confusing that we have now come to a psychological point, sometimes related to cell phone use in a negative way, that we've lost trust and we've lost hope. And the critical aim, if that's the case in our society, is that the loss of hope is the origin of suicide. So are we beginning to agree that we are on a termination course as a society, or are we going to refine ourselves, not only from our faiths, but from other ways that we can build trust with one another through social connectedness and through respect of each other in this changing world? And that's the challenge I think we're faced with now. So how do we get trust? We take our messages very seriously. And studies have shown that if we had handled the messaging better, we would have saved lives. But we didn't handle the messages better. We handled it individually and partisanly, and we I'm sure have lost lives for that. That's our challenge.
I also just wanted to add one more thing, Jamal, which is to say that trust is often built when people work together. In other words, when they work on a common project over time, and that can be any project in one's home. People who might feel they don't agree on much at all, if they have to rebuild a bridge together, or do a bake sale together to raise money for their school, they'll work together. When you are focused on the task at hand and learn how to cooperate. Sometimes our whole selves, when you bring your body and your activity, sometimes it's better than just when you bring your mouth by itself in terms of cultivating trust.
Yeah, it's an interesting thing, right? Because I think back to a tragedy in 9/11, right? Back when 9/11 happened, we kind of came together as a country, right, and supported all of those who needed support in New York. And it was a very patriotic time, if I can say that. And we all were sort of one mind. And I'm not sure if it was because as a country we saw that there was actually something to fight or what, but that's how I saw the country at that time. But when COVID hit, there was so many, like everybody disagreed on what we should do and how we should do it and how we move together. And it's just to your point of, even if we disagree on things, when there's a need, we see the need to come together, we typically can do that without an issue. But for some reason with COVID, it didn't happen. It had quite happened that way. And I think just like Dr. Flaherty said, it was to our detriment, which is sad to think that we it's something that we could have prevented. And thank you both for your answers there. Very profound. I have another question from Cassie, and they want to know if you have any suggestions to help support staff who are struggling with their own pandemic-related stress and anxiety while they support students. She's in the education setting and works on an online school, at an online school, I should say.
Hmm.
Well, teachers in general, much, like so many people, but particularly, I empathize as a healthcare provider, have had to had to shift so quickly to try to figure out how to provide online learning for their students, and which worked in some ways and didn't work in some others. And I think every teacher that I know would say it was a tremendous challenge. Again, it has some advantages for some people, but it was a really exhausting and a difficult time. Now, for teachers in general, and I wanted to point out to this in a more general way, is this place that we are in this transition, this endemic period. As we return to as we start to re-regulate ourselves and get back in relationships and back to work and back into interactions, we're coming into this situation significantly dysregulated, because human beings, mammals, if you have, pets in your household, you'll know that they depend on the rhythm and routine of the day. And as humans, in our usual forms of interaction, we help regulate each other's mood, and we give people cues about when you're not talking appropriately to a person in the right context. And a lot of people have been without those cues and guidance. And this is particularly clear with children and some young people, right? I've talked to a number of teachers who have had to, their children are back in school, and after being out of school for so long, it was really hard to get their classroom systems back in order, even though children were thirsty for it in many ways, that they came in after, months and months and months of not being in that regular pattern and having those regular cues. They had to relearn a lot. Now, for an online teacher, all teachers have worked very, very hard. And you have to figure out what are the aspects of your life that refresh and renew you, both within your workplace, like support groups from your peers and supports from your supervisors, but also outside your work. You get your life going back again, and start doing the things that nurture and support you that are available to you now.
If I could add a comment, I was thinking as Dr. Klein was speaking, that some people think that the issues of COVID are actually hiding some of the deeper issues that are behind COVID in our society. That focusing on COVID and how we, handled it is important, is critical important, because there may be another COVID just around the corner. That said, but there are deeper issues behind that in terms of the fabric of our very democracy that need to be addressed. And that's something I think is worth mentioning. But the question that plagues me in my mind is that if we look at all the resources and all that we had, and I certainly appreciate our teachers and service workers and healthcare workers, but of the 6.5 million lives who are currently registered as having died to COVID, over 1 million of them are in this country. So we're looking at 1/6 roughly of the deaths of COVID in this advanced society with a vaccination. And I think that's a great place to start, to say, well, why could we not have done better? We had more tools to do it. And that's where I would start with some of the questionings.
Thank you. Susan asked a question. How do you see systemic accountability through reimagining for agencies, medical institutions, politics, and media, all of which are fiscally owned at its most basic level, which at times is in direct conflict with the Baruch service paradigms needed by humans?
What was the last part of that question, Jamal?
Fiscally owned at its most basic level, which at times is in direct conflict with the Baruch service paradigms needed by humans. I'm not sure if I'm pronouncing that word correctly.
Paradigms, maybe the direct paradigms. Well, that's a challenging one. On the other hand, it's not new, right? That was true before the pandemic, and it's still true now, is that there are lots of factors that affect how healthcare is organized, delivered, prioritized, and paid for, and marketed. So those are enormous questions. I think those of us who have been in this space, are left the pandemic brought these things into relief, but the same questions regarding how do we get cost-effective, reliable healthcare available to all, I think that's the question of our age. There are always going to be financial players in that, and the more we can be conscious of those things, and any of us, the four people I see here, although I don't know the details of your lives, are probably all getting some of their livelihoods, or have in the past gotten livelihoods related to healthcare, behavioral healthcare, or nonprofit work. So none of us are free from those considerations, but I think we have to work together to try to be responsible in our use of that, and also wise. Understanding how incentives work in the system. I think when I look at trying to develop how to maintain both our current systems of care as well as develop new innovative systems of care, one of the things I tell our clinicians is, I want to work with you to think about what is the best quality of care that this patient needs. And then we have to figure out how to get paid to give it. So that's often requires a lot of creativity. It also requires advocacy, getting those things that are essential paid for. And sometimes it also means hard choices. Do you want to have this more expensive drug for one person with a slightly better outcome? Or do you want to have a slightly maybe less effective or drug with a couple more side effects, but we'll be able to treat two people with it? Those are very hard ethical questions that the healthcare system as a whole, as it triggers out how to use resources in our communities, have to face.
I would only add to that both Dr. Klein and I are very invested in what we call recovery-oriented systems of care or population health. And the one loud common statement in each of these pandemics and epidemics and catastrophic events over the last 200 years is that there are distinct populations who are higher at risk for the effects of those events. And they include what we call today social detriments of health, or recovery capitals. So we start building recovery capital in individuals. If we start building recovery and move away from keeping system or supporting systems that totally work on pathology, but recreating and retreating pathology, but getting pathology and then introducing into recovery, we may take this whole movement into a different kind of healthcare where we're actually paying for people getting well. Imagine that thought, and going with it and keeping people out of the revolving door of the current systems.
Thank you for those answers.
I just want to add a little bit to what Mike was saying there, which is that recovery systems of care depend upon those institutions of civil society, those places where people go for recreation and work and livelihood and purpose and amusement and socialization. So in addition to building those, the structures of formal healthcare, we really have to build and sustain those other aspects of our society so that those in recovery can participate fully in them.
Mhm.
Agreed. Michelle asks, I think that the worker shortage that we're seeing now is a result of the pandemic, and that the areas of the workforce where the shortages seem to be areas where we treated them first as heroes and then as the quote unquote bad guys, like healthcare, teachers, retail, social services, restaurants. So the workers either retired or and cause staffing shortages, or people don't want to go into those fields because they don't want to be subjected to that type of treatment. And the question then becomes, how do we get past that? Because I do, I work a part-time job and I work in a retail setting, and there is a number of shortages. We stay short-staffed, and you notice in markets and restaurants and things of that nature, that there are a lot less people working in those areas. How do we, get past that part of what the pandemic has done?
Hmm.
Or your thoughts?
I'll go first.
You have an answer.
If I had the solution for that, I would be very wealthy. But our problem is unique in that in behavioral health particularly, but also healthcare in general, we have been suffering a shortage of workers for decades. And the Annapolis Coalition, which I'm a part, have been saying this repeatedly, calling attention to it for over 20 years, as have others. But we are now beyond the crisis stage. And where do you come beyond the crisis stage is you come to the point where you realize you cannot fix the problem in the current systems. We don't even have pipelines in schools anymore to bring us sufficient numbers of behavioral health workers, whether that be psychiatrists, psychologists, social workers. We have some, but not many. The careers are not enticing to people. They aren't even going to community college to study it. This is long standing. So we have to find out, and this is what the Annapolis Coalition has been saying, we have to have a national leadership and state leadership program where we get out of the box. We build our peer supports, we build our family peer supports, we find extenders everywhere we can. We look at our population, some of which may be in jail, some of which may be in recovery, and find new workers, because we simply cannot do it in the current existing structure. We will always have waiting lists, and we will always be in a position where many of you know your waiting lists and your agencies are. I wish I could be more
No, I appreciate the answer. Dr. Klein,
I wish I had an easy answer too, and I don't. I think we need to recognize that there's a period of real exhaustion and burnout for folks, and that's natural, and that there's a cycle to that. And some people just need to take a break. Some people who take a break and really effectively refresh themselves may feel drawn back into the field, but we have to sort of, we just have to figure out how to get those needs met. My guess is we'll be doing some things differently, and I really count on the next generation of figuring that out. But I don't have any easy answers. And I'm sort of puzzled by the numbers. If unemployment is down to 3.5%, how is it? Well, I guess that means that there's a great demand for workers. So there's lots of competition. In our field of behavioral health, of course, salaries, face a lot of competition from other industries that are growing and getting back on their feet. So I think that's something that we have to address, and to make this work more attractive. I mean, I do say to all the clinicians, I think we have the greatest job in the world. To think about how people grow and develop and flourish, and when things get off track, how do we help them get back on track, and how do we help them cope with the deepest questions of life? I think there's no better job to have.
Mm-hmm.
Great.
Jamal, may I jump in for a minute here?
Sure.
As I'm listening to what we're all talking about, another piece of that for me has been how many people moved around. And it was mentioned by one of you, I don't remember who. And living in the city, one of the things that I experienced is I live in a high rise, and literally half the people in my building moved out within the first 60 days. And they all went to safer places, like Mike was talking about his island. And that changed everything dramatically around here. And also, people have moved away to be with their families. And I just lost another friend from my neighborhood who moved few weeks ago to be with his family. And I feel this loss of yet another friend. I can't have lunch with him anymore. We can't have the conversations that we had. We can't work on the same projects together. And it's really sad. For me, and I believe that that is part of what's impacting how the change too is happening. You know, maybe you had a job in the city and now you're out with your family and that job doesn't exist and you're doing something else. And I do believe that that's focused on mental health that I haven't heard a lot of conversation around. I'll stop talking and let you all say something.
No, I actually, Nancy, I think you do make a good point. Because I just look at it from a personal, point of view, right? Since the pandemic hit, we've been working from home, and
Yeah.
it's the losses that you get from there, like you used to hear stuff around the office about people leaving and going and things, and now I work very directly with my team, and I don't have all of the hubbub of the office chatter and things of that nature. So you lose a lot, and when people leave to go be with family and they leave the job that they have and maybe move down south to and start working in a different position, those things aren't I don't think talked about nearly as much as an effect on the workforce and things of that nature. So it's the way that COVID had the pandemic has affected everyone in these little small ways that you don't pay attention to. Like now going into the office, just driving into the office brings a greater sense of anxiety now. Like when I know I have to go into the office, that didn't exist before the pandemic, but now you worry about the traffic, it's all of these things that become these little concerns, and you feel these little tinges and you go, well, where's this coming from? I haven't had to go into the office on a consistent basis in the last 2 years. So it's been interesting for sure. And I think we're still processing how to kind of get through it on an individual level and as a community.
Mhm. Jamal, long COVID effects were detected 10 years after the 1918 and 1889 pandemics. People were still coming in for treatment 10 years after those events. So I expect we'll still see some of this for a while yet.
Mhm.
Agreed.
I have a question that I would ask, I'd like to ask our lovely audience. As I said earlier, the reimagining that we've heard talked about today, and another conversation that we could talk more about what we've talked about today, except move it forward to, so what can we do now? And how can we make things better now? Be more specific on ways to do that. And I'm going to ask that question, to our audience. I just threw it up on a poll, and I want to get an idea of what the interest is. Whoa, that's going fast. I think we've got the answer. What do you think, Jamal? I think it's yes.
Yeah, I think it's going to be, looks that way.
Yeah, this is, well, I appreciate that feedback. And I'm going to stop the poll. And I'm going to have a conversation with our two lovely speakers here today to see if I can't twist their arms and have them come back and continue the conversation with us. And Jamal, did you want to pick one more question before we?
No, I think because we're at 3:58 and I want to be mindful of everyone's time. I want to also thank Dr. Flaherty and Dr. Klein for their presentation. You provided us with a lot of information and things to think about as we move forward from here as a community. Thank you, Nancy, for being you and taking care of the things that you always take care of. And thank you to our participants for your very thoughtful questions and your participation in the chat. So thank you all.
Well, let me just end my part with, we're taking a break at this point, and we'll be back in January with our 2023 speaker series. And Dr. Deirdre Jackson is going to be back with us to start off in January. And I'm very excited about that. And you'll all be hearing more about that. Keep your eye on your email. I personally want to thank everybody for continuing to participate in our speaker series, to bring all that you have to our series, to keep us going through the pandemic and keep us moving forward with the focus of the children and young adults that we're here to support. And I thank you all for that. I will be going through the chat, pulling out any resources, emailing y'all with the link to the recording from today, plus the resources that we talked about from Dr. Flaherty. Should I give them a
Thank
minute
you
to
all
say
very
something?
much.
Can we do that, Jamal? Give him 1 minute to just say something before you
Sure.
cut us off.
Oh,
I just want to thank everyone here who participated. In particular, thanks to Nancy and Jamal and also Crystal, who made this possible, to Michael, our partner in crime. And we just appreciate all of you and all of you who are out there rebuilding our communities and keeping our behavioral health system functioning. We appreciate it. Thank you.
Just thank you again to everyone that Dr. Klein mentioned and all of you, and keep hope. You're the solution, not the problem. We need you to come up with the solution now. So keep hope and we'll get there. Thank you.
Thank you, Dr. Flaherty. Thank you, Dr. Klein.
thank you all. See you all next year.
See ya.
Adios.